I'm Alice Parks, Senior Health Correspondent for Time, and it's my pleasure to welcome everyone to the very first Time 100 Talks virtual event. My guest today is Dr. Anthony Fauci, Director of the National Institute of Allergy and Infectious Diseases and member of the White House Coronavirus Task Force. Today, we're going to explore and focus on the issue of COVID-19 and how we can find ways to find hope as we navigate through this pandemic. Dr. Fauci, I'd like to start with where we are today. We're a little more than a month into an unprecedented social distancing campaign in an effort to control this virus. President Trump has recently outlined a 3-phase plan for reopening businesses and society, ideally by May 1st. From a public health and scientific perspective, is it the right time to be talking about reopening the country?
Yeah. You know, I think it's important, Alice, to make sure that when we use the word reopening the country, that we have to realize that we're a large country that has outbreaks in different regions, different states, different cities, that have different dynamics and different phases in which they are in. And that was the reason why when we put together the guidelines for, as we say, reopening America, it was very, very careful and very conservative in making sure that you pass certain gateway points, checkpoints before you go to the next phase. I think sometimes, and understandably, people might think that when you get back to normal, it's like a light switch that you turn on or off. It isn't really that at all. So when you ask the question, is the country ready to start taking those tiptoe steps into loosening somewhat those mitigation strategies, which are fundamentally all have the common denominator of physical separation? No crowds, 6 feet away, wear a mask, close places that have a large gatherings, be they restaurants or concerts or what have you. That those are the kind of things that have actually worked to prevent an even bigger explosion than we've seen. And I think the prototype would be New York City metropolitan area, which has had a real terrible time. So when you talk about, is it the right time? It's only the right time for those areas of the country which have already shown that you're consistently going down in the number of new cases of COVID-19, the number of new infections, hospitalizations. It's a downtrend. Once you do that, you go to phase 1, which means there are still a lot of mitigation programs in place, but you could start relaxing a few of them. If you pass that for several days, you go to the next phase. So it's really a gradual re-emerging into some form of normality. The thing that concerns me, Alice, is that they're in the quest, an understandable quest, to get back to normal as quickly as possible, that there were going to be some regions, some states, some cities that might leapfrog over some of those checkpoints. And one of the problems with that is that's the danger of rebound, which at the end of the day would set us back on our ultimate quest towards going towards normality. So bottom line is we need to do it. We need to do it carefully, but we must have in place the capability when we do start to see cases come back, and I'll guarantee you they will, as we pull back on mitigation, we'll be seeing cases. If we have in place the capability to identify by testing, isolate, contact trace, get people out of circulation who are infected, that's called containment. If we are capable of doing that effectively, then we should feel some good confidence that we could slowly move on. If we don't have that in place, we better be really careful as we move forward. This is a very critical time right now.
You mentioned the checkpoints and talked about testing and how critical it is for moving into those next phases as we talk about reopening the country. I think you would agree that there were some stumbles early on with instituting the type of testing and the wide-scale testing that we needed in this country. How confident are you that that testing capability is now up and running and ready for what presumably would be a bigger burden of caseload for testing people, because it would seem to me that if we want to sort of open up a city like New York, nearly everyone might have to be tested. Is that right?
Well, not everyone, Alice, but certainly the ones that are felt by the physicians and the health authorities who are responsible for not only taking care of individual patients, but for containing the outbreak in their particular region. I would feel better if they have the confidence that they could do it, because sometimes there's a disconnect of what you project is out there with regard to resources, particularly testing. And then when you get in the trenches with these people, these very brave, dedicated people who are doing it, they tell you, there are glitches here. We can't test everybody we feel needs to be tested. I agree, you don't need to test everybody, but you should at least be able to test the people in which you have to test to be able to do containment. And right now, I think there's still some gaps there. I mean, on paper, it might look okay, but we absolutely need to significantly ramp up not only the number of tests, but the capacity to actually perform them, so that you don't have a situation where you have a test, but it can't be done because there's not a swab or not an extraction media or not the right vial. All of those things got to be in place. I am not overly confident right now at all that we have what it takes to do that. We're getting better and better at it as the weeks go by. But we are not in a situation where we say we're exactly where we want to be with regard to testing. I think anybody that has any realistic evaluation of what's going on in the trenches will tell you, again, we're doing better, and I think we're going to get there, but we're not there yet.
And right now, the US is doing about just under 1 million tests a week, I think, and it's been sort of stuck there for a week or so. How much does that have to ramp up, in your opinion, as we get to the point where, different parts of the country will start opening up?
So, Alice, that's a good question. The claim is now it's like 1.5, but it's probably 1.5, but maybe even a little bit less than 1.5. We need to do, in order to get the kind of testing in place that would allow to address blips as they come up. You see, the confusion is, in a perfect world, if you go so slow that you don't have outbreaks, then the amount of testing of 1.5 million to 2 million per week, you could possibly get away with that. I think you need closer to 3 to really do it the way you want to do it in the field. If all of a sudden you're talking about really pulling back on mitigation and getting out into an area where you'd have to do some containment of things that might be more than a little blip, you may need multiple times that as you get into the late spring and early summer. And for goodness sakes, when we get into the fall, after all of those months, we better have multiple times that, because in order to adequately respond to what you see as little rebounds, that's one thing. Then there's another whole aspect of testing, which we haven't tapped because we haven't had enough tests to do it, is to do testing in a way that not only is in response, but that's proactively trying to find out who is infected and who is not. So those are the things we have to have in place that we don't have optimally in place right now.
And you talked about how not only having tests, but being able to execute them, having the swabs, the reagents, all the other things needed to execute a test. What role does the White House Task Force play in that, in potentially bringing together commercial labs, public and private entities that can do these tests or provide the supplies for them? What role does the task force have in expediting that?
Well, the task force might make the recommendations and expedite, but the federal government with its multiple agencies, FEMA, HHS, CDC, the ones that are actually go out into the community, particularly the role that the CDC plays in being the public health agency of the federal government, but FEMA plays an important role. A variety of other agencies do. So in direct answer to your question, Alice, there needs to be a partnership. I mean, I think the idea that the federal government can do it all alone, it doesn't work. It's never worked. That's not the way our country is set up. But also the locals, they do need to have a partnership. So the federal government has to back them up. I don't think we could say they're going to do it on their own, alone. There's a lot that they need to do locally alone, and there's a lot they should be doing. But sometimes they're in situations where they need some assistance. They need some assistance with product. They need some assistance with implementation. They need a lot of things because they may not be able to do it themselves. So my view has always been, this is a partnership between the federal government backing up local and local being the ones that actually implement.
And testing obviously is going to be key as we slowly release some of the social restrictions and more people are out and mingling and going about their daily lives. Can you talk a little bit about herd immunity and what role that plays in our long-term view of potentially controlling COVID-19?
Well, yes, as many people know, but I'll just simply explain it, Alice. Herd immunity means that there are enough people who have been infected, recovered, and are now protected against reinfection in society as a whole, that the virus does not have the freewheeling capability of spreading rapidly because it bumps into people, if you want to make it a metaphor, and make it into a person with a mind. The virus is looking to infect people, but so many people are protected that it doesn't have the capability of exploding. And what happens is that the herd of people who are protected protect the people within the herd who are not immune. That's why they call it herd immunity. Now, the problem is that depending upon the efficiency of transmissibility, the percentage of people that need to be protected, i.e. already infected and protected, varies from infection to infection. It could be 40%, 50%, it might even be as high as 80, 85% or more. There are two ways that you get herd immunity. You get enough people infected who are then ultimately immune and thus protected, and or you get a vaccine that induces immunity. I mean, the perfect form of herd immunity is a vaccine that's 97% protective. I mean, to me, that's the epitome of herd immunity. But sometimes you need a combination of the two. You need a combination of people who have been infected together with a vaccine. Now, right now, since we don't have a vaccine and likely will not have one for months to a year, probably a year or more, as I've said many, many times, perhaps a little sooner, depending upon how things roll out, is that the number of people who have already been infected, even though it's unclear what that precise percentage is, because we don't know for sure how many individuals have been infected and are asymptomatic, because we haven't done that broad screening that would tell you what that is. But assuming that a minor percentage of the population has been infected, herd immunity doesn't work under those circumstances. So we really can't depend on herd immunity until we get either enough people infected or enough people vaccinated.
So until that year then, or so, until we get that vaccine, I'm assuming that the ultimate goal will be some sort of herd immunity for the world's population against this coronavirus. Until then, what are some of those? We continue the social distancing. From a practical perspective, what are some of the ways that we can then protect the susceptible from the virus?
Okay. Great question, Alice. And I can explain it best, I think, by telling you the two extremes. One extreme is what many regions, countries, nations, whatever, are doing, is essentially locking down. So you essentially are hiding from the virus as opposed to stumping it out. And if you do that long enough, the virus might ultimately whittle away to a low level until you come back out of hibernation, as it were, and then it'll be there. Now, locking down isn't just to lock down. It's to give you time to develop the capabilities to handle sick people, the testing capabilities, so that when you open up again, you can come out swinging, if you want to use metaphors. In other words, to have the capability that when you start pulling out of the untenable situation of being locked down indefinitely, which you can't do, that you have the capability is that when that virus rears its head, you have the capability to test, identify, isolate, contact trace, and snuff it down before it outbreaks. That is confronting the virus and suppressing it, as opposed to pulling back in a very extreme way and kind of staying out of the way of the virus. So what we need to do as we start thinking about getting out of this extreme physical separation, we do it, other countries do it to different degrees. China did it to the extreme. It kind of worked for them. I don't think we'd ever be able to do that in our own country, but they did it to the extreme. As we emerge from that, we have to have the capability to adequately respond when it reemerges, because this virus is so transmissible. It's not going to disappear, Alice. It's not going to disappear. It's going to be there until we can suppress it. And the way you suppress it is by what I was saying, in the absence of a vaccine, or wait until we get a vaccine and do both of them together.
And the fact that we are in lockdown, as you said, and taking the approach of hiding from the virus, it's almost a strategy of last resort. You appeared on a Time 2017 cover entitled "Warning, We Are Not Ready for the Next Pandemic." And you have talked over and over again, given your experience with HIV, that viruses are just waiting, to find new human hosts. Right. How did we get caught so flat-footed then? And how did we get put in a position where we had to hide from the virus instead of confronting it?
Yeah, it's a good question. Several years ago, associated with the scares that we had in 2005 with H1N1, and then the 2013 with H7N9, the bird flus that jumped species, but did not, fortunate for the human civilization, did not have the capability or efficiency of going from human to human. So if you were unlucky enough to get infected from a chicken to a human, you had a high degree of mortality. It ranged from 30 to 40%. However, the good news for civilization is that it never developed the capability of going efficiently from human to human while still maintaining a degree of morbidity and mortality. So we were lucky. So we put together a pandemic preparedness plan, which, talked about stockpiling things, talked about making our capabilities of having a response and ability to make a vaccine quickly, which we've done much, much better now, much, much more quickly. However, when you have, and I've said this, I'm on the record, that if you get the unfortunate right combination of an explosion, not a warning like, you get, remember back in 2009, we knew in April that we had an H1N1 swine flu. You made a vaccine, you had multiple months, and then when the winter came, unfortunately, the outbreak came when the kids came back to school and not in the winter when we thought it would. So even with our ability to make a vaccine, it wasn't that successful. But thank goodness it wasn't a particularly virulent virus. But when you have a situation where you have within a period of weeks to a month or two, you have a global explosion. This is unprecedented, Alice. Even with the 1918, 1919, you had that warning, we had an outbreak in the spring, and then we went through the summer, and then we had that big second wave that devastated. We didn't even have that now. It just all of a sudden appeared, and it appeared quickly spread because of the 20th century capability and of going in and going throughout the world in hours. Back then, it would take months to go around the world. Now it takes 18 hours to go around the world. The unprecedented situation of coming out of China, spreading throughout the world in literally weeks to months, and then have the unfortunate situation of having an unprecedented degree of transmissible efficiency and a high degree of morbidity and mortality, that multiple things happened. A, it overwhelmed the healthcare system of many countries. I mean, just look at what happened in the unfortunate situation in northern Italy. We were lucky that we almost overwhelmed our system, right at the brink. We had to do some emergency things, but it really, really stressed the healthcare system. There was no preparation back then that would have anticipated this degree. I mean, I remember when we were talking about, well, why don't we have X amount of incubators or X amount of this? The response by people of good faith was, well, we'll put a lot in there, but the chances of our needing that many are very, very low. And then all of a sudden you find out when reality hits, the unthinkable, that you were not as well prepared as you would have liked to be. So we will get through this. And when we do, and you'll hear me publicly and privately saying, we need to put this amount of resources in, I hope the recent corporate memory of the world will have us realize that we've really got to do that.
That brings me to another point, which is that you've disagreed with the president on a number of things, from the sort of rollout and the timeline of reopening the country, as well as on potential treatments like hydroxychloroquine, which the president said he'd be willing to take, and you've said that you think we need more studies on. Have you ever been concerned that the science hasn't taken priority as far as making decisions about what to do, how to respond, and when to do it?
Well, Alice, it's a complicated situation. I give the scientific and public health advice based on evidence. I mean, I'm a scientist, as you know. I'm a physician, but I also have a considerable amount of experience in public health because I've experienced and been through the response to multiple outbreaks starting way back from HIV/AIDS. And I will continue to do that. And I think that for the most part, you're going to see that is going to be the driving force. As much as there's a lot of noise out there about agreements or disagreements, in fact, the evidence-based recommendations in the end will always prevail. We just came out a couple of days ago at the NIH. We put together a committee of people who have vast experience in COVID-19 and public health to get together and look at all of the evidence and come out with some guidelines that will be updated in real time as new evidence comes out. That's going to be the driving force of decisions, evidence-based. Again, there'll be people who agree or disagree with that, but I believe that's going to be the predominant force.
And related to that, I have to ask you that, you serve on the White House Coronavirus Task Force, and recently the president tweeted a hashtag Fire Fauci after one of those disagreements. Everyone made a lot of that. What did you make of that?
Well, I meet with the president literally every day, and, there was no way he was going to do that because he had no intention of doing that. I mean, he tweeted it out, but, as he said publicly when they asked him about that's not even on the table. I mean, that's a lot of people who use me as the symbol of shutting down the economy, which, I mean, it's understandable, but not really real. I just give public health advice. What happens with the economy is something that people that are beyond what I'm responsible for. My job always is, and I've always done it, and I will continue to do it, is to give advice on the basis of evidence and science.
And going back to that science, it might still be early, but what do we know about the different strains of SARS-CoV-2, the virus responsible for COVID-19? What have we learned about it so far from countries where it has been, where it has hit really hard, like China and Italy, and even here in the United States? Are we getting any clues about, are there different strains, and does that potentially explain why some people get sicker than others?
Well, it's fortuitous, Alice, that you're asking me this question today, because if you were to ask it a few weeks from now, I could give a more firm answer. But there is literally yesterday and the day before some publication that was suggesting, if not showing, that there really is mutations that are indicating that different strains that are in different parts of the country, that the West Coast got a mutation that indicated a strain that was less virulent than what happened in New York, who got their virus predominantly from Europe. It's still preliminary. It needs to be investigated. So I hesitated to mention it to you, but I would not be honest if I didn't say, oh, no, because I just literally heard about this yesterday. That needs to be pursued. What it means, we don't know. We need to really look into it carefully.
Okay. And finally, on a personal note, I know that you're very physically active and that you treasure your daily runs. Have you been able to continue that tradition?
Well, the weekends, yes. I go with my wife to the C&O Canal, which we've done for, 37 years. That's 36 years that we've known each other and been married. I used to do it every day, but I now, if I do squeeze it in, it's at night. And I stay 6 feet apart from everybody else, but I do it. But I don't do it every day. I used to do it every day. So I would say I do it about four out of 7 days a week.
All right. And again, you're also a sports fan. So when were you looking forward to your first Nationals game?
Well, we've been having a lot of discussion about that. Whether it's going to be a classic Nationals game with stands that are full, stands that are half full so that there's physical separation, or, which is, I think, more likely, though I can't say, is at least if you want to get back to salvaging part of this season, it might be a televised only for all that matter, and people get concerned about that, understandably, but, watching a great game on television is better than not watching a game at all.
Good thing for all sports fans to remember. Dr. Fauci, thank you so much for spending time with us today. It's clear we all have a lot more work ahead of us as we adjust to a new normal, as we try to put COVID-19 behind us. And it's important that we learn from this pandemic so our next response is better. Thank you again for sharing your experience and your expertise.